Thanks, Matt. So I'm Allie Pollack. I'm a pediatric endocrinologist. We are so excited to have everybody here for our November session for DiSH Montana. As Matt mentioned, as you get settled in, do please introduce yourself in the chat with your school and your name. And if you're willing to put yourself on a video, even for portions of this, especially our discussion, we love that. So as we get started, just please keep in mind that diabetes and school health or DiSH, we're gonna go through the slide, I guess. Nathan, thanks. Our presentations and discussions do not create or otherwise establish a provider-patient relationship between any clinician and any patient whose case is being presented or discussed in a DiSH setting. And when discussing any student or patient, please omit any personal identifiers such as name, birth date. Consider whether you should withhold certain geographic or other data specific to a student or school that would constitute information protected by HIPAA or FERPA. And we can go through the next slide here. So we will be providing continuing education credit hours for those who are interested. And there are no relevant financial relationships with ineligible companies for those involved with the ability to control the content of this activity. The session is eligible for 1 contact hour, and successful completion includes greater than 75% attendance of this live presentation and completion of an electronic evaluation, which you should get a link for in the chat at the end of the session. The credits are issued by Logan Health. Logan, and I have to read all of this to make sure we all know what we're getting here. So Logan Health is approved as a provider of nursing continuing professional development by Montana Nurses Association, an accredited approver with distinction by the American Nurses Credentialing Centers Commission on Accreditation. If you do have questions about getting credit for this, Matt Larson, who you already met, has an email address listed here, and he can answer any questions. We can maybe back. Are we missing any slides there, Matt, that I should talk through about DiSH, or did we get it all?
No, I think we got it all. We can kind of visit about moving into the open conversation session after we have our presentation by Nathan. I just would like to say thank you to Dr. Allison Pollack for helping bring DiSH to Montana. And I'd like to say thank you to the DiSH Montana advisory panel as well. And with that being said, I do want to jump into our presenter because we want to get to conversations afterwards as well. This evening, or this afternoon, I should say, we're honored to have Dr. Nathan Bingham, who is a pediatric endocrinologist at Logan Health Children's Specialist, and comes by way of University of Texas Southwestern Medical Center, where he earned his medical and doctoral degree. Then he did a fellowship and residency at Cincinnati Children's Hospital Medical Center, and spent a little bit of time at Vanderbilt University Medical Center prior to coming up to Logan Health up here in Kalispell. And we're just honored to have him as a pediatric endocrinologist to work across the state of Montana. So thank you for coming this evening, Nathan. I'll pass it on over to you. And just a reminder to participants too, if you could please put yourself on mute as well as we move through, and then we'd love to have you come up once we start conversation. So thank you, everyone.
Thanks, Matt. Hopefully everybody can hear me okay. Is my sound volume all right for everybody?
Connect to a Wi-Fi network first.
All right. I gotta silence my own phone and stuff here actually. So, all right. Well, happy to be here. Thanks for the invitation to speak to you all. Thank you to all of you out there who are taking care of our patients while they're at school. We love interacting with you and really appreciate the hard work that you do to take care of these kids. So I was asked to speak about kind of sick day, DKA, ketones. I don't have any really financial conflicts of interest, and most of any therapies that I talk about will be standard and are FDA approved. So I wanted to start off with, our goals, and then some learning objectives through this are pretty simple. I think particularly for nurses out there and for, our goal is, of course, to optimize student health, but it's also to help them be in school and learning so they're not missing school or out of classroom. So as we discuss this, these are things that could possibly obviously take kids out of class, but our goal should always be to hopefully keep them in class as much as possible when able. So today I'll be just talking about, I am going to cover a little pathophysiology. That's what I love talking about, actually. So hopefully not too many eyes will glaze over, but I think it's important to understand kind of the, how DKA develops and where ketones come from. And so we'll do a little bit of that. And then, hopefully you'll walk away from this, be able to recognize when students may be at risk for ketogenesis, and then when and how to check ketones, manage sickness. And obviously when kids end up being particularly sick, they're usually going to end up hopefully out of your hands eventually and back home and in their caregivers' hands. But we want you to understand when that might be necessary. So this is, as I promised, a little bit of kind of how ketones develop. And, it's important to recognize that ketone development is actually a pretty natural process and a result of fasting, exercise, and or dehydration. It really comes from when fat is broken down and metabolized. And so particularly when insulin is low, different tissues react to the lack of insulin. So in the muscle, your muscles decrease production of glycogen, increase glycogenolysis, so the breakdown of glycogen. They decrease protein synthesis, and actually you get breakdown of protein, and that delivers amino acids to the liver, where they can be used to produce sugar, glucose by the liver, and certain amino acids can actually be used for ketone synthesis. So fat in the absence of insulin will decrease fat production, lipogenesis, and you'll get lipolysis, or the breakdown of fat, and those free fatty acids are delivered to the liver where they participate in lipolysis and eventually ketogenesis. So ketones are really just a byproduct of the breakdown, the metabolism of free fatty acids in the liver. And so, and this process is really stimulated by some of the counter-regulatory hormones to insulin, namely glucagon, epinephrine, cortisol, all increase ketogenesis. So the main ketones that we look at are acetoacetate, which can be broken down to acetone. This is what produces kind of the fruity kind of smell on patients' breath when they are in DKA. And this is acetoacetate is in equilibrium with beta hydroxybutyrate. So these are the principal ketone bodies that are produced. So I just want to walk through this slowly, and I have a couple of just kind of principal kind of points that I want to make. So DKA, or diabetic ketoacidosis, is really the product of insulin deficiency. Okay, and so as you walk through this, you can see that stress, illness, and insufficient insulin intake, what you end up with are an increase in what we call these counter-regulatory hormones, and those increase lipolysis, so that metabolism of fat, which leads to the ketogenesis and eventually ketoacidosis, where the pH of the blood is changed. These hormones also lead, and the lack of insulin lead to decreased glucose utilization. So that leads to hyperglycemia. You get proteolysis, as I mentioned, breakdown of protein, also leading to hyperglycemia. And then finally, you get breakdown of glycogen in the liver and muscles, and that leads to hyperglycemia. And I think what I really want people to walk away from this and understand is that hyperglycemia does not cause ketoacidosis. So they often go together, but one is not the cause of the other. They're both a product sometimes of insulin deficiency. But, I sometimes, yeah, and I know that's a subtle kind of thing to understand, but I think when you're thinking about, is a child at risk, we want to look at hyperglycemia as a possible sign, but most of the time you're going to have kids that are hyperglycemic and they're not going to be in DKA or even producing ketones. And that's because they have enough insulin around, but often their intake of carbohydrate has exceeded that ability of the insulin to kind of direct that glucose for use. So it's a subtle thing, but most we hear stories. Usually it's not nurses, it's other school officials, who, because they're afraid of hyperglycemia, are sending kids to walk up and down stairs or, go outside and run laps trying to, because they're afraid it's going to lead to DKA or other things. And so it's just important to understand that hyperglycemia itself does not equal or the DKA. Okay. So hope that makes sense. So that's kind of the principle. What leads to DKA is real insulin deficiency. And once you get this, you can get hyperglycemia, which can lead to dehydration, which can worsen the acidosis. Okay. So that's really all I really want to point out from this. So, so if it's not just hyperglycemia, when should we check ketones? When should we be worried about that? Well, blood sugar hyperglycemia, if it remains elevated for several hours at least, without explanation, then that might be a time to check ketones. So if you have a child coming in, after lunch and they ate an hour ago and their blood sugar is high and they're otherwise feeling well, if it's a short period of time, you don't necessarily need to take them out of class to check ketones all the time. If they have acute illness, they're sick, running fever, and then particularly if there's any nausea or vomiting, abdominal pain, and of course rapid breathing, and these would be later signs of ketoacidosis. But those are things that should prompt you to start thinking maybe I need to have this child check their ketones. So in particular, these days, with children on pumps, they can develop, it used to be that, we'd have most of our patients on injections, and, you could have a child that was not, didn't have their diabetes really well controlled, but if they were getting their basal insulin every day and pretty consistent with that, even though maybe the bolusing wasn't great or not as it should be, and they were hyperglycemic, they could almost never, end up in the hospital with DKA unless something really, occurred. With pumps, we do have to be aware the pumps only use short-acting insulin. So if anything interrupts that for a number of hours, they could start developing ketones within a few hours. So this just shows kind of what that looks like. With automated insulin these days, if a child is receiving the insulin and the pump is delivering that automated insulin, these the automatic kind of boluses and increased basal, you will rarely see a patient with blood sugars 300 or 400 plus for an extended period of time. You just rarely see that. If you see a flat line like this on their tracing, you can look at their pump or their phone and it's been hours, then you do want to start thinking about an interruption of insulin. So in this case, this is just a kinked cannula that led to this kind of period here. And so that's something to be aware of, and that eventually could lead to ketogenesis and difficulty with that. This is just another tracing. Again, this kind of call them flatlining. It's almost like a EKG. They flatline along the top, though. When that occurs, in this case right here, this is insulin's been interrupted, and so or they ran out of insulin in their pump. And so again, they'll have blood sugars usually 300 to 400 plus, and kind of just flatlining along the top. And again, you can look at this usually on their on their pump or their CGM on their phone. So when we check ketones, the most common ketone testing is looking at urine ketones, and there are some disadvantages to urine ketones over checking blood ketones. This will be what most students have, or just ketone strips for urine. Blood offers some advantages. It's usually early detection compared with urine. But urine tends to be cheaper and easy, and so it's the most commonly used testing. And so usually you'll have a bottle of ketone strips, and you can dip a urine sample and see if they have any ketones being produced. So if a child is acting sick, not feeling well, it's never wrong in those cases to check ketones and know where your status is there. And we tend to start to get a little worried when ketones are, moderate to large. Sometimes small ketones can occur in a fasting child who's, smaller. And so kind of putting it together with their clinical presentation, whether they're feeling well or not, is an important thing to do as well. Just be aware that, the colors on the strips and the timing for the color change can vary according to brand. So just kind of pay attention to that on the bottle, what the instructions are. If you use it, there are strips out there that have a scale for urine glucose and urine ketones. So just make sure we're reading the correct scale. Just follow package instructions about expiration dates, time since opening. So that can be important. Ketone strips usually expire 6 months or so after opening the bottle, but that can vary according to brands. So just make sure that you're looking at that. If the bottle's been opened and sitting in a room for a year, they're probably expired and should be discarded. So how quickly does DKA progress? I mean, it's usually hours to even days, so depending on the control of the child. So, as I mentioned, particularly with pumps, you are talking about an hour or so, or maybe a couple hours. So you do want to, be aware of that if they're on a pump. But also remember that an isolated high blood glucose in the absence of other symptoms is not usually a cause for alarm, and particularly if it's after lunch or you have a good reason to suspect why they have hyperglycemia. So most endocrine departments will have kind of directions for their patients on how to kind of manage sick days. So when they're otherwise sick with non-diabetes related illness, and it's just important to realize what illness does to a patient with diabetes. So infection, usually will raise the blood sugar, and you always need insulin, even if they're unable to eat. Usually they need to be getting some insulin. Although you may need to adjust their insulin dose if they're not eating well. Ketones are usually a sign. Remember, it was lack of insulin that causes ketogenesis. So usually the presence of ketones mean they need more insulin. And we don't want that to progress. So that's where we're trying to kind of intervene early in that case. DKA is a medical emergency. And then, hydration. Hydration is important. And so if blood sugars are high, then we want to use non-sugar containing fluids, avoid caffeine. If blood sugars are lower because the child's ill and not able to eat, then we can offer fluids with sugar in them, in the attempt to actually raise their blood sugar so we can give them insulin and suppress that ketogenesis. And then, this is the directions we usually give to our patients. If they're vomiting 3 or more times, we ask them to call us if they have moderate to large ketones, and then to let us know if a child's having surgery or a dental procedure where they'll not be able to eat. So this just a little, when children are sick with diabetes, to make sure that we instruct them to check their blood sugar every 2 to 3 hours as necessary. Always take your insulin, so they shouldn't be skipping insulin doses necessarily. And drink lots of fluids, so hydration is important. And then check ketones if blood sugars are running high and you are otherwise ill. So most physicians, endocrinologists will also have some type of tool, kind of flow sheet or directions when sick. There are a number of variations on this. There's no real, right way to do this per se. I'm sure the other providers on the call, their clinics have certain ways that they manage sickness. We give our patients a kind of flow sheet like this, where they are instructed to check their blood sugar, check ketones, and change their bolusing habits depending on what their blood sugar is and what their ketone status is. And most importantly, remind them to increase their fluid intake, and then to be a little bit more cognizant of checking every 3 to 4 hours, and making sure they're kind of repeating this whole step every 3 hours or so. And this is what we put on the back of our card, that we give our patients. If they're vomiting should always induce someone with type 1 diabetes check their ketone status. So, very often we hear in the hospital, oh, they were vomiting, but, I thought they had a stomach bug, and so should always check ketones, and it's always assumed to be diabetes related until proven otherwise. So, and then we just instruct them, if they have a couple of times of vomiting, especially with ketones, to call our office. And then, as I've already mentioned, for pump users, it becomes particularly important because they can, they're on short-acting insulin that disappears relatively quickly. And you should always, so if you have a child with a pump, always assume the pump is not delivering insulin, that they do have if they're developing ketones, they're not getting insulin. And so they, particularly in today's, auto insulin, if they're developing ketones, assume they're not. And so we tell them to go ahead and change their site, so that they can hopefully be getting a basal rate, but give corrections by syringe until the ketones are essentially trace or small. And so that should always be remembered, I think. If they're on long-acting insulin, you don't stop taking that, and then remember hydration. So treatment of ketones, really they should get insulin and treatment per their DiSH-MT. I would encourage you as nurses, obviously, for anything that you do, to keep kind of a record of what's going on there. If they were given insulin, what their ketone status was, make sure they are free to use the bathroom, that they are given access to water or other sugar-free liquids. And then if they have ketones developing, we do want to, in that case, actually limit physical activity, which will increase adrenaline and worsen dehydration if it's occurring. So they shouldn't be participating in PE that day if they've got some ketones developing. And of course, if vomiting or lethargic, parents, guardians, and or medical assistants should be contacted. So that's a brief introduction to sick day guidelines and ketones.